Dear Minister of Health and corresponding representative, I'm here today on behalf of the Federal Medical Association of Psychiatry Students in India to propose a new guideline plans for tackling depression in India. This is the estimated prevalence of India. We believe that due to lack of knowledge and underdiagnosis is closer to 39.6. Women, urban residents, low caste and tribal people are at higher risk of developing depression. Depression is a significant socioeconomic burden, which translates in loss of productivity. The suicide rate is 14.7. This is just an estimate and is definitely the tip of the iceberg of the problem. Lack of mental care health facilities definitely hinders the quality of care to provide for those patients and quality of life consequentially. It is estimated that for 1 million people, there are only 3 psychiatrists. These estimates are even lower for psychologists. Therefore, the question that remains is that we need definitely to move forward. How? That is the question. We hope with our proposed plan to actually tackle this issue and provide a solution. We are facing obstacles and barriers that prevent us to tackle depression nowadays in India. Primarily is coordination of care, and this translates between primary, secondary, and tertiary care providers, but also there is a lack of coordination among the different sectors, such as the educational, the economical, and the healthcare sector. The second aspect which we have is access to care, which is very important. This in particular includes affordability, accessibility, and quality of care, which are still behind in nowadays. Thirdly, we have a lack of healthcare supply, in particularly healthcare workers and medical supply, and we also have a need to increase finances for mental health services, especially focus on prevention. Last but not least, we need to have in place a follow-up and monitoring system, which at the moment is either absent or inefficient in the majority of the country in India. In order to tackle this barrier, we need to reassess the current treatment. This slide, as you can see, proposed and is an overview of the mental care facilities and treatment that are offered for depressed patients. We can see that the GP has a definitely central figure in screening and selecting depressed patients. He does that via history taking and healthcare questionnaires, and accordingly, he categorizes them as mild, moderate, or severe, and he refers them to the appropriate form of treatment. Nowadays, in particular, is used the drug treatment of antidepressant. However, we can see that all in all, this current treatment is not working. There are several problems in this current treatment plan. Firstly, there is not enough medical care workers for the follow-up, and not a lot of psychological treatment are actually being offered. Secondly, enormous shortage of psychiatrists is present, and this definitely hinders the quality of the tertiary care facilities. And finally, the drugs that are being used are expensive, and even fluoxetine, which is the most economical one, still comes with a substantial cost. This leads to increased healthcare costs for the whole health system. This is an overview of our proposed guidelines. As we can see, one of the main changes is that we move from the central figure of a GP to instead a central figure of the community healthcare worker, or also called ASHA. They will be primarily screening a patient for depression, and they will do so via a combination of screening questions, history taking, and health questionnaire. We're definitely going to emphasize in early detection. We're going to do so by asking the ASHA to ask these 2 basic questions in every consultation that they will have, even in unrelated one. If one of the 2 results positive, then the ASHA will move forward to investigate via these Kessler Psychological Distress Scale questionnaires, as is illustrated in this slide, to investigate further the depression and possibly the severity. ASHA will in particular focus on the risk groups, which are homes with recent trauma, patients suffering from comorbidities, and students facing final exams. We also would like that the depression hotlines, which are nationally available, will refer directly the patients, of course only if the patient consents, to their corresponding community healthcare worker to integrate them directly into the structure of the plan. Once ASH identifies a depressed patient, it will categorize him or her as either mild or moderate and then address them to the corrective treatment. The treatment both for mild and moderate is a combination of treatments which includes also informal counseling and psychoeducation. By the MANAS trials, we already saw that this type of treatment can be done directly by the ASHA themselves and they is effective. One key element that we would like to emphasize is the introduction of the monitoring. So it's the ASHA will monitoring constantly the patient in a definitive period of time to reassess the condition of the patient and whether it is still mild, moderate, or severe, and accordingly adjust the treatment. And in the case of definitely severe patient, they will refer to a clinic of specialists and therefore for a psychiatrist. I would like to talk a little bit more in depth on what it entails the psychoeducation program offered by the ASHA. As we can see here, we have an overview of the health activity programs. On the right-hand side, we see that the focus is to improve the mood of the patients. How we're going to do that is a combination of several techniques which aims at changing the coping mechanism of the patient and of course using cognitive behavioral therapies in changing behaviors and attitudes towards the depression of the patient. By different trials, this health activity program has shown to be very effective in tackling depression in mild and moderate depressed patients. Once again, I would like to propose the guidelines and I would like to discuss these current guidelines and how they solve the issues that the current guideline is facing. So coming back on what we previously mentioned, we had the element of coordination and the lack of coordination between the several levels of care. As we can see by these proposed guidelines, we aim to tackle this issue by creating a close collaboration among the community healthcare workers, the primary care physician, and the secondary and tertiary care facilities. Moreover, the second point was the access of care and the limited access of care for the patients. By using and utilizing community healthcare workers, we strongly believe that this will be reduced because it will allow the patient to have a direct connection with a community healthcare worker or a healthcare facilities that can provide the care that is needed and therefore refer them directly. Thirdly, we discussed about the problem of financing, which is definitely one of the key issues. The use of community healthcare workers, as was already promoted by the MANAS trials, is not only effective, but cost effective. That means that we'll allow to use the limited resources that we have for mental care facilities in a more efficient way and cost effectively. Finally, we introduce a key point, which is monitoring. As we can see in clinical practice, patients suffering from depression not always have the same severity, but they tend to fluctuate. Therefore, their treatment plan cannot be constant, but needs to be reassessed through the course of the time. And by integrating the monitoring, we believe that this, again done by the ASHA, will allow better quality of care for depressed patients in India. I hope that this proposed guideline was clear to you. We shall remain at your disposal for any further questioning. And we would like to thank you for your attention. And I would like to conclude with a motto: happy people, happy country. Thank you very much.